morat se javiti. Ja ću sad.
It should be switch, so you can see the two slides and we can only see the presentation. Yeah.
It's not quite. Now it's good, Julian.
Yeah.
Thank you.
Good morning, everybody, and welcome to the second day of the third Evidence-Based Research Conference. Today, the first keynote session here at 9 o'clock is a little changed according to the first plan we made due to the time zone issues. We have two presentations from Australia, and it will be the middle of the night if they were going to give the presentation late this afternoon. And thus we have combined the two Australian today, but both of them are in two different theme sessions. So we will have one presentation by Arianne Verhagen, and then we will have the question and answers to that presentation, and then we will have the presentation by Julian Savulescu, and we will have the Q&A there. So hope that will be all right for you. You will also notice that we will have the same themes in the last and fourth keynote session this afternoon around 4:30. So both themes are covered in both sessions. So our first presentation is by Arianne Verhagen. Arianne is professor and head of the discipline of physiotherapy at the University of Technology in Sydney, Australia. And we have identified a very, very interesting and important paper by Arianne and a group of colleagues from the Netherlands about actually the title of the study is do we need another trial on exercise in patients with knee osteoarthritis? No new trials on exercise in knee OA. So in that way, we find that very important in relation to the question, when is enough, how to decide when we do need more research, as Arianne and her colleagues have made a very nice piece of work with this. So please, Arianne, the time is yours.
Dear all, thank you for inviting me for this conference, and thank you for joining me for this presentation. My name is Arianne Verhagen, and I am Dutch physiotherapist and clinical epidemiologist. And at the moment, I am working as the head of the discipline of physiotherapy at UTS in Sydney. I am asked to present a paper that I published in 2019. The title of my presentation is No New Trials on Exercise Are Needed in Knee OA. And in the next 25 minutes, I will tell you all about the why and the how and how we did it. So let me first introduce my team. During the bulk of my research, I was part of a team at the Erasmus Medical Center University. Along with some of the highly esteemed kind of osteoarthritis kind of researchers like Marienke van Middelkoop, Sita Bierma, and Jos Runhaar. Two of the team members are part of the National Health Institute, which I'll explain later. And for the second aim of this presentation, I asked Manuela Ferreira from the Sydney University to join me and help me with the fancy analysis and the difficult things. So just on a side note, this team is, apart from one man, only females, and I think we did a wonderful job. So Jos Runhaar is the only male in the team. So let me first start with a bit of the background on the why of this study. In the picture, you see in some of the slides, you see these kind of nice fancy pictures. They're from the new library of UTS, and everyone is very proud on that building. It is an award-winning building, and it just opened just before the pandemic. So we're now starting to use it, and that's fantastic. So in the Netherlands, the Minister of Health requested advice from the National Healthcare Institute to evaluate whether exercise was effective in patients with hip and knee osteoarthritis. With effective, the minister liked to see an effect that was clinically meaningful. And if effective, it would mean that treatment of people with hip and knee OA would would get part of the reimbursed physiotherapy sessions as some other conditions are. At that moment, it was not reimbursable under the healthcare scheme, so that would be, in our view, beneficial. Nevertheless, several Cochrane reviews already existed, and they all showed that exercise was effective, especially compared to no or minimal interventions. And that was the question of the minister. We want to know how effective exercise are compared to doing nothing or use your kit. This means we had to answer the minister, we had to update it to the Dutch situation. And that means that we had to update the reviews of the Cochrane and be a bit more selective in the study selection. So we're not able to see Tai Chi or home exercises as exercises, because the minister definitely wanted physiotherapists to do the exercises. But also the control interventions, they did not accept ultrasound or ineffective treatments anyway. So we had to be a bit more selective. So what are our study aims? These were our aims as presented here. First, of course, the main aim was answering the main question of the minister. But as a research team thought, is that how many trials do we need to do on these kind of research questions before everyone accepts it's effective? Because in our team, we already thought this is an effective intervention. So why bother? Why bother doing another systematic review? That's also the reason we never published a systematic review, because we couldn't get us doing that. And some of us already were finally concluded that a study on this aim was redundant and should not be funded anymore. And that's why we added a second aim. Can we calculate how much data we need before we can change the effect estimate to something that's not clinically worthwhile? And assuming that we would find a clinically worthwhile effect size, of course. The next slides, I like to explain how we did and how we tried to answer the study aims. But I also assume that most of you are a bit familiar with the basics of a systematic review. So I'm not going to deal with that in depth. I'm just going to explain you the basic things. And I will focus in this presentation on the extra analysis for the second aim, because that is the fancy analysis, and that is the analysis I would like more people would like do these kind of analysis to help the research community not conducting redundant studies in this field. So we did a systematic review according to the Cochrane methodology at that time, and this was in 2016. So you have a bit of an area where you can see what normally used to be done in these systematic reviews. We used the data that was already collected in the Cochrane reviews, including the risk of bias assessments, and we did and next to that we did a transparent and reproducible and whatever kind of search, and we ended up with over 9,000 hits. We assessed the risk of bias using the Cochrane neck and back review group kind of tool. At that time, there was no risk of bias 1 or 2 yet available at the Cochrane, so every research group, a review group, had their own tools, and as musculoskeletal researchers, we were very familiar with this one, so we used this one. And for one reason or the other, the existing Cochrane reviews also used this tool, so that was easy. The outcomes of interest were the minister would like to have response to treatment as the main outcome, but we already thought that's not going to work. So we also mentioned in our study protocol that we would assess pain and function. And the minister would like to have long-term outcome. And we thought, whoa, we're not sure whether that's doable. So we said we do it immediately post-treatment, 3 months after treatment, 6 months after treatment, and 12 months after treatment. And this is how they wanted to see it, what happens after treatment, not after randomization, because the minister is not a researcher. So it was after the intervention. These are all kind of different things you need to know before you can interpret the outcomes. I must say in this presentation, I focus on the outcomes of pain immediately post-treatment, because this is the bulk of the studies and that makes it fancy to analyze. So first, the analysis consisted of 5 steps. The first step was that we did an ordinary, normal kind of analysis for a systematic review. So we did a meta-analysis using a random effects model, and we used grade to grade the evidence. And next, or grade the certainty of the evidence or the quality. And next, we evaluated possible publication bias, because we thought that might be interesting to see if nothing is over there forgotten. And our analysis, this analysis on publication bias was just eyeballing, because we don't feel that the analysis given for publication bias is very valid and robust. And you can see by eyeballing, you can see a lot. For the second aim, we did a step-by-step evaluation of the robustness of the findings we found. And at the end, we calculated how big a new trial, or how big the effect estimate of that new trial should be, to change the pooled estimate to something different than we found in the basic analysis. So publication bias, as I said, we also did a bit of heterogeneity. So we looked at subgroups. We have looked at every subgroup you can imagine. So we had a priori an immense list of subgroups we thought would be relevant. I'm not going to present everything to you, but I do present a couple of them. We did a cumulative estimate, meta-analysis, to see how the pooled estimate will fluctuate over time. So how robust is the effect estimate over time? And this is the last one. We did an extended funnel plot to see what the impact is of new data when we add it. Please join me in hearing the results on these 5 steps. This is a bit, it's turned around. This is the lower bit of the funnel plot, the forest plot we made about pain. This is the responders. Yeah, the responders, we had just 8 studies looked at responders. And that was the minister's primary outcome measure. And well, as stated before, this is a dichotomous outcome measure, you responded or not. The problem a little bit was that every study defined that differently, and some studies did not even provide data for us to calculate. So we ended up in 8 studies doing this. And the official analysis has 52 studies, so it's just a minority of people that looks at responders. And what you can see here is that the pooled effect estimate is 28% increase in number of respondents when doing exercise compared to nothing. And what you see over time is that it reduces to 5 to 6% and starts being significant, statistically significant. This is the top of the funnel plot of the forest plot on pain, and it includes 51 studies, because one of the studies did not mention any pain outcomes. And what you see, it's a huge table. It's really, really huge. And this is just the upper half to give you an impression how a full-blown forest plot looks like with a lot of studies. I don't see that quite often. And this one is the bottom part. And what you can see on top, my picture is in front of it. I'll move that. I'll move that a bit. What you can see on top is that we have a 0.5 standardized mean difference in the immediately after treatment estimate, and that reduces a little bit to 0.22 or 0.27, and it stays all the way statistically significant. The clinical meaningful effect we a priori set at 0.38, and that was based on previous studies. So and the minister was happy with that one. I'm not sure why. So only the post intervention diamond showed a clinically meaningful and statistically significant effect. The rest was statistically significant but not clinically meaningful, as according to our a priori set cutoff. So what about publication bias? We were able to include 42 studies. I'm not sure why, because that was on pain also. Oh no, that's just post-treatment people. This is 24 people, 24 studies included studies that had an outcome just immediately after the treatment. So what you see on this picture is that on the x-axis you see the effect size on standardized mean differences, and this is the pooled effect size when we pool everything, like I showed you on the previous slide. Oh. On the vertical axis, you see a kind of measure for the size of the studies. This is a lower size, so a smaller size of studies, and this is the bigger size of studies. Normally, a funnel plot should have kind of this kind of shape, like a real kind of funnel, and this one is remotely looking like a funnel. And normally the bigger studies have a more precise estimate, and then it goes down to there with a more variable estimate in the smaller studies. What this plot shows you two things. First, that all studies were more or less the same size, because it all bulks here together. And second, left and right from the vertical line, you have about more or less the same number of studies. And the idea is that on the left side here, you should have less studies, because publication bias means that you do not publish then the small and negative findings, small studies with negative findings. And we clearly do not have the idea. We see that here or here. Oh, it's the other way around. It should be here, the empty spot. But normally one of the spots should be having an empty part of the lower part of the funnel. That is the publication bias. So we concluded from this slide that we don't have apparent publication bias. Looking at heterogeneity, as I said, we have an enormous amount of subgroups evaluated, and the main ones I'm going to show you is first how osteoarthritis was defined. And you had a couple of studies that they only had clinical criteria for inclusion of patients, and another bulk of studies had radiographic selection criteria to include people in the trial. And that's a subgroup we evaluated. We also looked at the duration of the intervention, and we took a cutoff point of 12 weeks. That was actually a kind of convenient cutoff point. We did not a priori mention that, but we wanted to have a bit of equal groups, and this makes sense because in the Netherlands, osteoarthritis treatment, duration is normally about 12 weeks. And then we did look at whether you give exercises in a group or individually. We also looked at exercises in water or on land. The hypothesis is that if you are doing exercises in water, you don't have the body weight compressing the painful joints. So the idea was that could be more beneficial. And the last one is that we also looked at a risk of bias. So we pulled only the low risk of bias studies compared to every study, or the high risk of bias studies. And the ones in blue did not show differences, and the ones in red were showed differences, and these differences markedly. So in group exercise, it doesn't even reach our clinically worthwhile defined effect size, while in the individual group, it is rather big. And also the studies with low risk of bias had a little bit of a higher effect size compared to everything. But that was not a big difference. The only remarkable difference was this one. Good. This is a cumulative meta-analysis. I have difficulties with the word, so stay with me. The plot represents the cumulation of studies over the years. So on the y-axis, you can see the different years. The first study started in 1992, and every time we added a couple of studies and we entered the next year, we added these studies to the pooled effect estimate. So these are all pooled effect estimates except the first one. And the horizontals are the 95% confidence interval of the pooled effect estimate. So over time, it started in 1992. We had the first study, and we ended in 2016, where when we did this final analysis. And this plot shows you three things. First, none of the 95% confidence interval crosses the line of no effect, and that's here. So actually, every pooled effect size was statistically significant. Second, from the beginning, almost all pooled effect sizes showed a clinically relevant effect. Maybe not this one, but the rest is probably eyeballing about almost near 40. So a couple of these early ones maybe not reach the clinically meaningful effect size, but definitely the later ones do. And third, the effect estimate starts to be stable from 2010. So our conclusion was A, it is effective, statistically significant, B, it is clinically meaningful, effective most of the time when we have enough studies in it, and C, the effect estimate is robust over time. So we can say that this is the effect size around 0.5 that probably will be representing the real effect. So we also boldly try to say that all studies after 2010 were redundant. And the last thing is the extended funnel plot. This is a different plot, and bear with me, I'm going through it. It is rather colorful. And what you see here is the same plots as we had with the publication bias. So the same studies were in the plot. This is the line of our clinically worthwhile effect. This is the dotted line is the line of our pooled effect size. And the red area here presents any new study that has a dot in this red area that will represent here in this red area will contribute to the meaningfulness of the effect size. Even make it bigger when it is more to the left, make the effect size bigger, but still clinically meaningful. And because of the bulk of studies, smaller studies that might not be effective still do not change the effect size. The green area is any new study that is in the green area might change the overall effect size to clinically not worthwhile. So on the other end of this straight line. What you see here is that a study should not only be very big, bigger than most of the ones we had, but also have a huge negative effect size or a huge positive effect size. But the smaller ones need to have a huge negative effect size. An effect size we don't see because these are the two ones that are most negative. So we, based on this thing, showed that we think that no new trials can change it to unclear whether it's clinically worthwhile. You also see here a blue area. Normally these plots also have a kind of blue area where it changes to not clinically worthwhile. So we can't think about any study big enough or have a big enough effect size that changes the effect size to clinically not worthwhile. So this is why we, therefore we think that no study can change these effect size to anything remotely like unclear or not clinically worthwhile. Good, and this is a bit of a larger discussion because sometimes things seem to be very easy, but we went on from the easy thing and thinking, what does it mean and why? So how did we go from here? Well, first we had a conclusion. This is the title of the, come on. I have a bit of a problem with the slides. Yep. So this is the title of the publication. And in that publication, we conclude that exercise is effective and clinically worthwhile when compared to no or minimal interventions, and that adding new data doesn't change the conclusion. But that is the simple and the effective, this is a simple answer. But we went on because the answer to our second aim is also clear. We do not need any new data, but how do we make sure that people understand this message? Because this message has been given before. Manuel and I were part of a study looking at exercise treatments compared to no or minimal treatment in low back pain. And we concluded that was not effective. And this was the first time we trialed this fancy analysis that Manuel is very good in doing. And we published that paper in the BMJ in 2012. And we were thinking, nobody took that message. What happens? Why isn't it? We had a feeling nobody took that message. So how do we make sure that the uptake of the message is going to be in a way that it helps, that we actually help the research community? So this was a study we published in the BMJ. And then we thought we have to investigate whether this study had any effect in less new protocols and less new studies. But one paper is just a case. So we thought, is there any other message in any other remotely similar area? And we found a Cochrane review on the management of chronic pain that actually gave the same message. Was also published in 2012 when we found it. I think it's now updated. But also that study in 2012 mentioned that CBT was effective in the management of chronic pain and should be delivered. So we then went on with another study, and that other study had the aim, do the number of protocols reduce or change, differ after the publication compared with before the publication? So do people take up the message of we don't need another low back pain trial or another CBT trial from when it's published? So we thought about how to do that, and the only way to do it is to look at published protocols. So we analyzed a number of trials registered in the WHO before and after the recommendation, and we took a certain time window way before, not very way before, but shortly before the recommendation, but another time window a bit longer after the recommendation, because we need people to give people the time to understand the message and change their behavior. So we calculated the number of protocols on both specific research questions and in the WHO register, because that is the largest trial register we're aware of. And a priori, we defined that a time frame before and after the publication would be slightly adjusted halfway, because the number of CBT trials was 10 times different than from the low back pain trials. And we also a priori defined what we call a change. And we said it should at least have a difference of 20% to call it a real change. So then we thought, well, we're not looking at the numbers per se, but also if there is a difference between the uptake of CBT or exercise in low back pain, we might have a look at what kind of factors these publications differ. And I'll show you the table, because remarkably, we found over 20% increase in low back pain protocols, addressing the same question as we did the recommendation on, but also an almost comparable reduction of the ones in CBT. So this is the increase, the relative change of protocols, because you can see there's way more registered after the late in the 2016, 2017 than before. So we did a relative change, and we found about 33% increase of protocols compared to a 32% decrease of the protocols on CBT. So the funny thing is, what constituted to this difference? We had a good look at it, and we finally came to the conclusion, this is, by the way, the publication. We finally came to the conclusion that the publication should be visible. There is a way of dealing with it. It's the recommendation should be strong, and media exposure makes a difference. The visibility of our low back pain trial was 0, because whatever we tried and whatever search strings we tried and whatever we did, we could not find, based on low back pain protocols, trials, new trials, adding data, whatever, to find our low back pain publication. Although it was published in the BMJ, we were not very looking very good. We were so focused on explaining to the research community how fancy the analysis was that we developed, that we didn't think about the visibility of the message we actually gave underneath. So also our Cochrane review by itself is visible, and the recommendation in the Cochrane review was in the abstract. So if you do whatever you do, you find that one. So the strength of the recommendation was also different. We were very, very, very cautious in saying, well, better not to do any new trials, while the Cochrane review was blunt. Don't do any new trials, not necessary. And there was a difference in media exposure. First, we thought, well, the impact factor of the BMJ is way bigger than that of the Cochrane, which is, at least at that time, but their media exposure was way, way bigger than ours. Let's see if I have some data. Yeah. The media exposure of our low back pain paper, we had an altmetric score of 21 based on 30 citations. The same moment, the Cochrane review had an altmetric score of 110. and 586 citations. So that's a way different way of citing things. So how did we do with this paper? So far, I just looked at it yesterday. We have 22 citations, 85 captures. I'm not sure what it means because this journal, the Osteoarthritis in Cartilage, doesn't give me an altmetric score, but they do give me these data. So it has 22 citations and 232 social media posts. Unfortunately, some of these tweets were related to a person, a man, with the same last name as me, but not in this area. So it is sometimes very difficult to find yourself back. We didn't think, when we published this paper, we didn't think about it, but this is something we learned. But what we did nice was we did put the outcome very bluntly in the title. So that's all good. But I think we might do a little bit better on the social media thing. And that's something I learned now. So my take-home message from this presentation is just publishing your research is definitely not enough. We all know that, but we all forget to make it better. And we all are so worried with the next publication or the next grant application you need to write or the next student that comes along that we don't think a lot about that. So a publication is kind of selling your story and your message. So my recommendation would be if you have nice conclusions on the study, and always have a look at whether you can come to a clear, clinically worthwhile, nice conclusion, put it in the title. My feeling of being an editor on the systematic reviews portfolio of one of the journals, I feel some people just stop after the analysis. And then they have a kind of conclusion like it's unclear and we need more and things like that. These are conclusions that are no longer viable. There is always some juice in the results that you can highlight. So I would really recommend to think about a clinically worthwhile conclusion and highlight that in the title. And it would be nice to tweet these things and not just a Twitter thing and then think, oh, done, well, fine. It needs to be repeated. So I noticed for myself doing this presentation that it would be good to improve my media capture of this paper. And you can all help me. You can all help me by tweeting this presentation, tweeting the take-home messages, or tweeting the paper itself. And I'm very much looking forward to your tweets. And I will retweet and I will do a lot of things. I will try to like them, retweet them, but do mention my real name. And I'll give you my real name. This is my email, and that's my Twitter handle. So I would like to thank you for your attention for this presentation, and I hope you enjoy the day. For me in Australia, it's night, so I will enjoy a nice glass of wine after the Q&A. Thank you so much for joining me.
Thank you very much, Arianne. Very interesting. I hope that we can arrange that the two of us are in the focus here.
That would be nice. My camera can't go on.
Oh, okay, okay.
Please try now, Arianne.
Yeah. Yep.
Yeah,
Thank
very
you.
good. Yes. Thank you, Arianne. Very interesting. And I think we have you know, the question about getting the message out there. I can tell you that in another study we just have performed, we have identified, I think, more than 270 studies worldwide dealing with exercise for knee osteoarthritis, where most of them are actually exactly evaluating exercise versus no intervention or placebo or something like that.
Yeah.
And again, most of them are published after that you and some others have clearly indicated that we do not need that.
Yeah.
What do you think of that, Arianne? That's really problematic.
Well, there is a bit of a lead time after our publication. If you have got a grant for a study that actually is not needed, you want to finish it. But I do not think that is the main problem, because I don't think a lot of people get a grant for these kind of studies. It's mainly clinicians that are very enthusiastic and do these trials. And are not always aware of what's out there. So I think a lot of these unnecessary studies are done by very enthusiastic clinicians that want to prove that what they do is right. Yeah.
But how come, have you met anyone? You are very much into this area. Have you in your work met some of those authors and know anything about what's going on in their mind, not using a systematic review? I mean, it was clear that Marlene Fransen's study from 2015 and the Cochrane, it clearly indicated only with I think it was around 47 studies or something like that. So
I'm not sure what that is, but I think not everyone is on top of the evidence. And if you're researchers like you and me, and you want a grant, then you have to put in the grant the existing evidence. But if you do it on your clinical in your clinical time, and you just select these patients while you're clinically working, you don't need to know everything about what is out there. And I think that is definitely part of what's happening, because most of the studies are small. There's not hundreds of people included, and you need a grant to make it hundreds of people. So if you do 50 in one group and 50 in another group, that's doable in clinical practice. And I think that is what's mainly happening. I'm too much a researcher. I don't speak these other people on a daily basis, but I do speak a lot of clinicians, and they are always very enthusiastic about thinking about trials. And whenever I ask, have you looked in the literature, what's out there, they have no clue. They just have no clue.
Well, I think I will, to me, this is a take-home lesson with this example, that when we are promoting this approach, the evidence-based research approach, we should go further than just in quotation mark, the researchers. We should just as much look at the clinicians, because suddenly one of them become a clinical researchers, because they would really like to evaluate this particular question they had worked on maybe for their whole career or something like that. There's also some questions, Arianne, about how do you know when it is clinically meaningful? And you know, the reason you and Jung-Wook Ben was put together in the beginning was because both of you had been considering how to know when it's enough, or how to know if a systematic review is conclusive and so forth.
Yeah, I must say that clinical meaningfulness or clinically worthwhile effect size kind of thing came from Manuela, and she did in low back pain a couple of studies to define clinically worthwhile effects. Low back pain is not the same as knee osteoarthritis, although it is musculoskeletal, and you can guess there will not be a lot of difference. It took a long time before we found a kind of effect size that was recommended as clinically worthwhile in literature on osteoarthritis, but what we found was a 0.36 or 0.38, and we just made it a 0.38. You have to do something if you want to make a definition on clinically worthwhileness. It would be nice if the half the world know the size, but that's so new territory that I think we just borrowed a little bit from low back pain, and some study we found somewhere saying that it was something like 0.36, 0.38, and we combined it in 0.38. It's a choice. It is a bit arbitrary, and if people want to change it, feel free and find evidence for the proper worthwhile effect. But so far, this is what we had.
There was one question about whether the plain language summary maybe could help. I mean, you if you're preparing as a researcher, as an author of a systematic review, and if you are making a plain language summary, you have something that you could take out and share. You could link to it in a Twitter. You could share it in many different occasions.
I only know the Cochrane making plain language summaries. And as a Cochrane author, I know that it is extremely difficult. So I'm not a person that speaks a lot of jargon anyway, but I find it too difficult to make a plain language summary. And always the Cochrane consumer group makes these a plain language summary based upon what we try and what we send. And every time I try a plain language summary, some of the consumers tell me, that's not enough. No, I'll go to revise it completely because this is no one can understand this. So it is very difficult to make a plain language summary. And Cochrane is doing it. And I'm not sure whether a lot of other journals do it. I know BMJ Sports does something like a patient leaflet kind of stuff, but this is not for patients. This is for researchers. I have no idea whether there are actually plain languages for researchers. That would be fine to develop.
What do you think? There's actually two other questions here. There's one question about the trial registration, and there's the question about guidelines. What do you think? How should we deal with the possibility of demanding much more registration? Would that help in reducing this large number of really unnecessary studies?
I'm not sure. Just an honest question. When you plan a systematic review, do you check Prospero to see if that's already existing?
Yeah. Well, I do.
Although then you're a rare person, because a lot of people doing a systematic review don't check Prospero to see if that's already there. And I think trial registries are way bigger and are difficult to manage because the whole search strategy, defining the search strategy, making it possible to find things took us a month. And it's a very difficult thing to search in anyway. And the Prospero is easy compared to the WHO or any other trial registry. So I don't think people search a lot there. We in the Netherlands, it is in the guidelines. So it's taken in the guideline is now exercise is better than knowing intervention. But I'm not sure whether a lot of clinicians will, or a lot of researchers look at that, or clinicians, and say, but maybe my exercise is definitely better than someone else's exercise. I'm not sure how people think, but that might be a case.
But is that maybe an expression, this experience that you have and we have had comparing this large number of redundant studies even after your publication? Is that maybe because the clinicians are not using guidelines?
Maybe.
Yeah.
I mean, we don't have a look, and then what does a Dutch guideline tell you? Who is able to read it anyway? Yeah, all kind of practical problems, Hans.
Yeah, but I think that the last comment here in the chat is really that we maybe some positive spin would be very smart. And I mean, your title in the study was somehow a positive spin. No new studies on the exercise for knee osteoarthritis.
We need to see if that really happens. The time window we had after the last publication, that was 2012, the time window went from, I think, 2014 to 18. No, 2016 to 2020. So we took a rather large lead time. So maybe if we wait for 2, 3, 4 years, we might see if it reduces. Yeah.
Hopefully, I'm afraid that the data we have right here now, being searching in every corner, is showing the opposite. So it's very challenging. But I think we have to move on, Arianne. Thank you very much for this presentation and taking your time. It was
Thank you
very
for
good.
asking me.
Yeah.
Thank you for asking me. Was a fancy thing to do.
Yeah.
Thank you. Bye.
Okay, our next presentation is also another theme, and that's really looking back to move the evidence-based research forward. And it is by Julian Savulescu, actually one author I love to read. Julian is the Chen Su Lan Professor in Medical Ethics and Director of the Center for Biomedical Ethics at the National University of Singapore. And together with Ian Chalmers and someone else, they actually published a study in '96 So when we ask about looking back to move forward, it was very interesting to have a point of view from you, Julian, about what are the status since the paper in '96. My impression is that it's just as disappointing as the former presentation, but
Yeah.
that's up to you to let us know. Please.
Thanks very much, Hans. It fits very well with Arianne's presentation. So before I go on to the talk properly, I'll just talk a little bit about the rationale for this paper and how it fits into the previous presentation. So back in the mid-90s, Ian Chalmers was very exercised around two things: failure of people to do systematic reviews and take account of existing evidence, and the failure to publish negative results. And I argued that not only was this sort of bad scientific practice, it was unethical, that it resulted in harm to patients. And we had various examples of people being denied proven antibiotic treatment for infection, for example, after cesarean section, as people continued to do placebo-controlled trials. So with respect to the previous presentation, it's unethical to deny somebody an effective treatment for their pain or their loss of function from osteoarthritis or low back pain. What we did was to say, look, actually, this is a responsibility of ethics committees. Ethics committees are allowing harmful research to occur, research that denies 50% of the participants a proven medical intervention. So when one of the questions in the chat said, how are we going to stop these clinicians or these small-scale studies occurring? The obvious way to stop them occurring is through the ethics committees, because clinicians still have to get their research approved by an ethics committee. And if ethics committees were aware of the ethical implications of publication bias and failure to do systematic reviews, then this sort of research wouldn't be approved, because you would be approving something that denies 50% of people an effective treatment. So that was the general argument. And I'm an ethicist, so I'm not an epidemiologist or a person who's expert in systematic reviews. I only became interested because in many cases I see ethics committees failing to actually facilitate good research and then also allowing unethical research to occur. So I wrote this paper in '96 with Ian Chalmers, and then subsequently this paper with Ian and Rustram Al-Shahi Salman. But going back to the '96 paper, the 5 recommendations that we came up with, which I was asked to speak on in this conference, were have these recommendations been taken up? And as you've heard, they haven't been taken up. So I'm going to give you yet more evidence that none of these recommendations have been wholesomely taken up. So really, I'm telling you something you already know, but I'll perhaps show how ethics committees should be more concerned with this as a condition of review. So first of all, require systematic reviews. Secondly, provide a summary of the relevant systematic reviews to potential participants. To register trials at inception as a condition of approval. Require a commitment to publish or make publicly available the results of research, and to audit the reporting of results of research previously approved. So, 25 years on, have these recommendations been taken up? Well, it's true that systematic reviews are now recognized as important to justify and design research studies, including randomized controlled trials. And this can potentially reduce research waste. But still, many randomized controlled trials do not perform or reference systematic reviews. There's also, which wasn't mentioned in the last excellent talk, increasing concerns about the quality of systematic reviews themselves. And there's an increasing glut of low quality systematic reviews, which are themselves a form of research waste. So tools have been developed to help authors improve the quality of systematic reviews. And one of the upshots of my review is that these should be more extensively used or required by ethics committees. Not just that systematic reviews be done, but that good systematic reviews be done. So there are large numbers of low quality studies occurring, which also makes the job of conducting systematic reviews difficult. This was particularly acute during COVID-19. And publication and citation bias continue, with industry studies being less likely to be published if there are negative results. Negative results are less likely to be published in the abstract, so making it difficult to find some studies even if they are published. And another topic I'll briefly discuss is whether systematic reviews should also review the ethics approvals of the trials they refer to. So COVID-19 raised many new challenges. The extremely fast-moving area of research led to redundancy, low-quality research, and raised new questions around research waste, where there is pressure to do many trials at once, and where many similar randomized controlled trials are being done. So, I mean, here's an example of the current requirements for, I just picked my local hospital. I'm sure you can find many other examples of what research ethics committees are currently requiring. So the Royal Children's Hospital, one of the best 4 children's hospitals in the world, says researchers should provide a focused review of findings from previous related studies. Even the national body, the National Health and Medical Research Council, responsible for funding medical research in Australia, sees systematic reviews as important in grant applications. So it's recommended that where such reviews exist, researchers refer to these. So neither of these require systematic reviews, as we argued in 1996. In fact, the Children's Hospital doesn't even mention them. Indeed, if you look at international policy, in the UK, the MHRA, regulatory body, does not mention systematic reviews. The NIH recommends that clinical trials should begin with a systematic review, and they suggest consider doing a systematic review if appropriate one does not exist, but they don't require it. And EU regulations do not require systematic reviews of clinical trials. So not only do ethics committees not require them, the regulatory bodies don't require them. So, you know, I briefly mentioned why these are important, but it's important to ensure that evidence relating to the research question has been considered before justifying and designing a clinical trial. Now, I mean, the most acute example of this occurred, which I'm sure you're all familiar with, 6 years after I wrote that paper with Ian Chalmers. A 24-year-old woman, a laboratory technician, Ellen Roach, died as a healthy volunteer in an asthma trial at Johns Hopkins University, one of the world's most premier medical research institutions. And she was given hexamethonium to inhale to provoke mild bronchoconstriction to study physiological mechanisms in asthma, and subsequently developed fibrosing alveolitis and died of respiratory failure, multi-organ failure. Now, the relevant researcher, Alex Togis, conducted a Medline review and turned up 4 studies that mentioned hexamethonium and mentioned no side effects. In one of those studies, all of them were extremely small. One of those studies, 2 patients did develop pulmonary complications, but they weren't felt to be related to the hexamethonium. But if you went back to the 50s and 60s, it was regularly documented that hexamethonium had a side effect of fibrosing alveolitis. And anyone doing anything more than a cursory Medline search would have turned up these studies, which were also present in many standard textbooks. So the failure to do a systematic review of hexamethonium killed Ellen Roach. So that's an obvious lethal consequence. But if you're doing trials involving life-saving drugs, then you will foreseeably cause people's deaths by denying them drugs which are known to have life-saving effects. So again, Another example, which I give in my talks, is probably the most famous clinical trial is the ISIS-2 trial that showed that streptokinase reduced mortality after acute myocardial infarction by about 20%. Okay, and this is held up as the gold standard of evidence-based research and effectively changed research practice around using clot-busting drugs. But it was known before this trial started, with a p-value of about 1 in 10,000 from systematic review, that streptokinase reduced mortality from myocardial infarction. So even starting this trial was controversial. So I was very interested in the previous presentation about how to decide when enough evidence is enough. And I don't believe that the streptokinase trial was even justified in the ISIS-2 trial was even justified in studying. But let's assume it was. After the randomization of 2,000 patients, the data monitoring committee of the trial, led by Sir Richard Dole, who established the link between smoking and lung cancer, one of the world's most famous epidemiologists, said that the endpoints had been reached for the trial, that it had been shown to reach their endpoints of statistical significance. But they went on to randomize a further 8,000 people to placebo, even after the data monitoring committee had judged the statistical endpoints had been reached. And they gave various justifications for this around having to have very high levels of confidence that would change clinical behavior, having to be very certain that the drug had an effect and was safe and so on. And those arguments may be correct, but I did a rough back of the envelope calculation and something like 130 people died in the placebo group because they didn't get streptokinase. So even when you don't see somebody dying at the end of a needle, there will be people dying when you deny them an effective life-saving treatment. And this also shows why the choice of when enough is enough is an ethical decision. So, I was very interested in that one critical slide about deciding when trials wouldn't, yield any more, would not be able to shift the confidence intervals around meaningful effect. But essentially, whether you settle for, in the streptokinase trial, a p-value of less than 1 in 100,000, or you were satisfied with a p-value of less than 1 in 10,000 at the beginning, is an ethical decision. It involves balancing harm to future patients, about accuracy in cost effectiveness calculations, versus the interests of these particular participants. So the question of when enough is enough requires systematic reviews, but it also requires ethical decisions around balancing different values and interests. Okay, so that's my sort of rant about the ethical importance and why ethics committees should take this more seriously. So there are 3 criteria for the ethical justification of randomized controlled trials, according to de Müller-Meester et al. Clear hypothesis, equipoise, and uncertainty established by a systematic review. It's unnecessary, as we heard, to do a further systematic review if one already exists. It's of sufficient quality, it's up to date, and the quality can be assessed by various tools. So are systematic reviews being used? This is not occurring, even for research published in very high quality or highly ranked journals. So here are just a few examples. In 2013, a review of trials in the Annals of Internal Medicine, BMJ, JAMA, Lancet, New England Journal of Medicine, only 1 in 35 randomized trials used an updated systematic review, and 13 in 35 discussed previous systematic reviews. In 2018, a randomized cross-sectional analysis of JAMA and New England Journal of Medicine, only 54% cited a relevant systematic review or meta-analysis. In 2022, a mean percentage of 17% of clinical studies used a systematic review to inform their design. So that's unethical, and research ethics committees should not be accepting those sorts of proposals. Now, since I wrote this piece with Ian, a further problem has emerged of low quality systematic reviews. And Roberts and Kerr argue that systematic reviews can cause research waste themselves by promoting underpowered trials and over-inclusion of low-quality trials, which can inflate treatment effects, requiring a systematic review on a topic where a previous systematic review may itself constitute will constitute a form of research waste. And in 2019, a total of 80 systematic reviews were being published per day, up from 11 in 2010, many of them from China. So, even back in 2010, one article said 75 trials and 11 systematic reviews a day. How will we ever keep up? So again, systematic, I'm not suggesting systematic reviews are the silver bullet, and themselves have raised significant problems. So a 2017 survey of systematic reviews of surgical randomized control trials found only 2.8% were of high quality and 89.4% were of critical low quality. So it's got more complicated. Not only do ethics committees have to require systematic reviews, they have to require quality systematic reviews. And in my view, ethics review now has become so specialized that you need people with ethics training, but you also need people with training in how to conduct and evaluate systematic reviews. So the old model where you had an institution and you got a doctor and a lawyer and a chaplain and a layperson, and that was your ethics, what may have been satisfactory at some point in medical research, but it's unsatisfactory today. And indeed, regulators and reviewers don't often have sufficient expertise to make judgments about the ethical justifications for trials, and that the ethical justification is inextricable from the scientific justification. Inclusion of low quality trials introduces bias and introduces conflicts of interest. And the obsessive zeal on the part of some people conducting systematic reviews to find every published trial can even result in completely fraudulent studies being included. One Cochrane review on the effects of high-dose mannitol had to be retracted after it emerged there was no evidence that any of the included trials actually took place. So we also have the problem of scientific fraud infecting the quality of research, which wasn't such an issue back in 1996, but such a public issue, but is now a very clear problem with much research. Some of the causes of low quality research, as I'm sure you know, is the incentive to publish quantity over quality, funders prizing novelty, short-term deadlines, researchers knowing too little about methodology, lack of transparent reporting. So one of the issues which has come to light since 1996 is raising the question of whether systematic reviews should also record the ethical approval of the studies. And I think this also applies particularly to Chinese studies, although the kind of quality of the ethical approval may be dubious in some places. And the authors of systematic reviews are doing relatively little to identify research malpractice and misconduct. Ethics is not included in the quality appraisal checklists such as Consort, and some have argued that we should propose adding ethics review to appraisal checklists. So we're continuing to see research not being published. So in 2018, a study of Alzheimer's disease and cognitive impairment research identified 744 relevant clinical trials from 1995 onwards. And there have been problems of research fraud in Alzheimer's disease, particularly around 10 years ago. 67% of these were industry sponsored, and the odds of non-publication were much higher amongst industry sponsored research. They were also much more likely to be discontinued. 73% of the completed trials were not published, representing nearly 100,000 people who incurred the risks of trial participation without contributing to the medical literature. So that's an ethical issue that research ethics committees should be concerned about. There were also a further 18,000 patients from unpublished and discontinued trials. The second problem of publication bias, null results are less likely to be published. Review of antidepressant trials registered with the FDA showed that 100% of positive trials were published, only 47% of negative trials were published. And a paper is more likely to be cited if it has positive findings, an author with authority, the journal impact factor, the number and quality of the diagrams. It has, and it has already cited, highly cited publications. So our second recommendation was to require that a summary of relevant systematic reviews be made available to potential participants. Well, given the problem of the quality of systematic reviews, it's hard to see how this could easily be achieved. Indeed, a 2011 systematic review of what potential research participants want to know about research makes no mention of research participants wanting to know about prior existing evidence. And indeed, surveys of experts also places making available research, previous examples of research as a low priority in plain language information statements. Third recommendation was to require registration of clinical trials at inception. There has been immense progress in clinical trial registration, and it's now considered an important part of clinical trial research. Trial registration policies have been implemented by funders, journals, professional bodies, governments, and there's a major new EU initiative this year. But a key remaining issue is the enforcement of these policies requiring registration. And another issue is that when trials are registered, often the protocols are not adhered to. So persisting problems are that trials, even though there's a requirement to register them, are not registered, and that the final results and publications do not actually follow the protocol that was registered. There's an enormous literature on selective outcome reporting in clinical trials. For example, a 2019 study of clinical trials in ophthalmology journals found that only 64% were registered, and of these, there were discrepancies with the primary outcome in nearly half. Fourth recommendation that we made was a commitment to make the research publicly accessible, the results of the research publicly accessible. Key challenges remain in selective outcome reporting and enforcing policies requiring the publication of research results. Beyond the summary of results, the public sharing of raw data sets for critical appraisal and replication is rarely adhered to for a variety of reasons, including lack of time, lost data, too much effort. In many cases, the raw data is not made available to patients. COVID-19 saw one particular initiative, and that was the move to rapid preprint studies. And this has had various positives and negatives. It increases the speed to research communication and being free to read, but there were concerns about premature media coverage of preprints and public sharing of information from peer review. A 2014 study reviewed the reasons why research is not published: lack of time or low priority, incomplete studies, publications in preparation or under review, negative results, poor quality of study design, or fear of rejection. Another qualitative study from 2014 found that authors admitted to contributing to publication bias, but recognized that it was a major problem and unethical, but felt that publication norms and practices created an environment highly biased towards positive results. PLOS Biology has introduced a category of pre-registered research articles that undergo peer review after study design prior to the research being conducted. This would be an important initiative. And research ethics committees should require a commitment to make research results publicly available in some form. As I mentioned, less than half of the data sets stated to be available on request were actually able to be effectively obtained when authors attempted to obtain them. And various reasons such as no time to search for the data, data had been lost, data was protected by agreements. A 2015 study reported the researchers had concerns over control of data, as well as declaring that data sharing is simply too much effort. Privacy concerns around releasing data. Dual use is another important issue that's has arisen since 1995 around the publication of controversial results. Another concern is the global north-south divide around publication. Researchers in the global south have fewer resources to reach publications behind a journal paywall. And it's also more difficult for researchers from the global south to be able to pay for open access. This leads to research from the global north frequently being more accessible than research from the south, which also has related effects on lower citation counts. There continue to be problems with industry funding. A 2016 study found that meta-analyses of antidepressant effects were 22-fold more likely to have negative statements about the drug whenever one of the authors was an employee of the manufacturer, where they were less likely to have negative statements. A 2017 Cochrane review of industry sponsorship and research outcome found that industry-sponsored trials more often had efficacy results that were favourable to the sponsor's products. And our last recommendation was that ethics committees should audit the publication of results and the conduct of research. And again, this doesn't seem to have been done, and that's primarily because of the lack of resources of research ethics committees. They generally have high workloads, their members are volunteers. And as I argued back in the 90s when I was the chair of a statewide ethics committees, we should pay ethics committee members generously to do a job and then require them to fulfill these kinds of commitments. So, you know, one of the upshots, I think, for the future of ethics review in this area is I think we need to professionalize. We need to have people with a much deeper understanding both of ethics and the conduct of research, including the conduct of systematic reviews. And we need to pay people to do a job that is seen through from start to finish. Let me finish there and take some questions.
Thank you very much, Julian. Thank you very much. I'm thinking about this issue about the ethics committees, what their focus, and please correct me if I'm wrong, but I would put up a suggestion. I think that the focus upon taking care of the participants in a study as test persons is very high level in an ethics committee, and the internal validity of the studies. And if I look at Manuel and Grady and Wendel's study from 2000, the 7 principles for ethics, the first one they are mentioning is value. And I have a discussion with an ethics committee in the northern part of Norway years back, and they're not thinking about the value of the study. Is that ethical really the principle for taking into consideration what we have talked about here, that it's really necessary? And they told me there's no room for us to put it on the list. It will be too much for us to take that into consideration as well, because they are overwhelmed by work already.
Well, I mean, that shows they don't understand what their role is. So ethics committees basically have two functions. One is to protect the interests of participants, and the other one is to ensure they give adequate consent. But to ensure they protect the interests of the participants, they have to ensure that the risks of the study are reasonable. So that means, first of all, that they are as small as possible, that they're necessary, but that they're also balanced by the benefits. Okay, so every research study involves some level of impact on people's well-being, even if it's taking up a day of their time. But if you're going to go through 10 weeks of a randomized trial for an intervention for osteoarthritis, it's quite a significant burden on you, particularly if you're doing something that's pointless. So the risk or the harm of the study has to be balanced by the potential to benefit them or the potential to benefit other people. So it's a mistake to think that all research is, the idea of equipoise is really a myth, except at the very beginning of a study. Equipoise is very quickly disturbed. The question is, how much is it justifiable to disturb it? And so you can't evaluate the ethics of a piece of research without understanding its benefits as well as its burdens, because they have to be balanced. Otherwise, you wouldn't do any research, or you're just trusting somebody to say the research has value, and that's totally inappropriate. The value has to be proved. The value has to be demonstrated through argument and existing evidence, such as it is. And that evidence might just be animal research or preliminary physiological evidence, but there has to be some case for doing the research. So it's just incorrect that ethics committees can't consider the value of research. They have to.
But thinking about the problem we are facing, all the studies made that it really putting people on unnecessary risk and waste of resources and all those arguments. Just think about it. When I listen to your presentation, I can see at least 3 groups that we could approach. The first, of course, is the ethics committees. The second is actually the researchers themselves, and the third one is maybe the authors of systematic reviews. I mean, we have realized in many different ways that what the Cochrane the influence Cochrane have on original studies, it's so much higher, because when they are making a systematic review pointing out this is a poor quality, here we have the problem with this, here we have the problem with that, and the results and so on. So it had an influence on the way that the future studies are being made. So authors of systematic review can highlight the problems. Ethics committees can, be a gatekeeper, but researchers themselves are also in a very strong culture force of publish or perish, continue to do your work because you got the grant, even though you suddenly realize that this is completely waste of time. I have a specific individual from Denmark who told one of my colleagues that we know it is waste, but we got the money and there's a demand for us to do the study. So what where do you think we should approach?
Well, you could try to start a kind of revolution where the 3 parties that you talk about are absolutely essential. But I would add to that journals, because journals shouldn't be accepting articles without a clear rationale for commencing them and doing a review. So the journals could be rejecting them, and then you'll find pretty quickly they will be doing them. And funders shouldn't be, like the National Health and Medical Research Council shouldn't be funding research that hasn't done or plans to do and report a systematic review. So I think you can and evaluates the quality. But I think with your comment about the Cochrane, I think what this whole idea of having institutional review boards, as they're called in America, where each hospital or each institution has it's just outdated. You need super specialized review, from experts that, not good meaning folk who are, in charge of something so critical, which is essentially people's lives are at stake in these in these decisions. And I mean, another trial which I wrote about was, there was in 1999 a young man called Jesse Gelsinger died in a gene therapy trial, and this man had a genetic disorder called OTC deficiency, and he had a mild version of this, which was compatible with the normal life expectancy. You could have done the trial on infants with a severe version that's lethal in the first year of life, and the trial should have been done on the infants, but the ethics committee decided that adults had to consent. And this is in line with World Medical Association guidelines, that we should do risky research on people who can consent. But Gelsinger had everything to lose and nothing to gain. The infant had nothing to lose and everything to gain. So this was in my view, an unethically designed trial. And the same thing happened with He Jiankui, that he took normal infants, normal embryos with nothing to gain and everything to lose. Whereas if you'd taken embryos with lethal conditions, such as Tay-Sachs disease, you could have defended his trial. But so, this isn't something that just an ordinary person can just, I've spent 25 years or 30 years, thinking about these issues, and they're complicated. Systematic reviews are complicated. Ethics is complicated. It's not something that just a group of people who do a weekend course can actually, grapple with.
There's a question here where it actually, now we typically we're talking about the randomized clinical trial where we had, comparing a group with placebo and the unethical of giving them something not working when we know it's working. But what about other kinds of study? It could be observational studies, it could be qualitative studies, it could be register studies. Or what